Chicago. Well, good morning. It certainly is an honor to be here with this esteemed panel, and I thank the IHPBA and the Executive Committee for this very kind invitation. So this is a topic I feel very passionate about, which is how can we improve identification of IPMN at risk. I have no financial disclosures, but I will show some data from some of our patents that look at some of the biomarkers of high-risk pancreatic lesions. So how big of a problem is this, really? We know that the identification of cystic neoplasms of the pancreas is increasing. And if you look at this data from Memorial over 20 years, you can see that the number of patients being treated per year for pancreatic cysts has exponentially increased per year, while the size of the cyst has dramatically decreased. So now that the median size of the cyst being evaluated in most of our clinics is about 1 to 1.5 centimeters. And why is this? Well, cross-sectional imaging, 15% of the time, is mostly incidentally finding a pancreatic cyst. And we know from autopsy studies that a quarter of all people will have a pancreatic cyst, and 20% of those, if evaluated, may have atypia or carcinoma in situ. So we can all agree, or most of us in this room can agree, that high-risk cysts and most MCN should be resected, but the dilemma really arises in IPMN. So evidence does support a progression model from low-grade dysplasia to carcinoma, much like in other malignancies, but the time frame for this transformation, alternatively, is not as well known. And in the absence of obvious radiographic findings, these high-risk cysts cannot be identified preoperatively, and the talk after mine, I think, will look at some of our guidelines. The first guideline, of course, were the original Sendai criteria. And these were fantastic to have something to follow because malignancy was being captured. But this was at the expense of excision of many low-risk cysts because of the very low specificity. And so the guidelines appropriately reacted, and about 6 years later were updated. And we know that those decreased the size limitations and also increased the surveillance, including with EUS. But how were these doing? So the largest studies looking at Sendai-positive lesions showed that many of them were still low risk on resection, up to 65% in this study. And at the same hand, many Sendai-negative lesions were in fact high risk. And in this study from the Heidelberg group, up to 25% of their Sendai-negative lesions were in fact high risk. And so the response to this around the world was to create new guidelines. In Europe, there were European guidelines. In America, the AGA guidelines. And so how do the AGA guidelines do in America? And I won't get into the details. Again, those will follow later in the session. But at least in the AGA guidelines, 45% of high-risk IPMN are still being missed. So with all these current guidelines, how are we as surgeons doing in choosing our patients for resection? So what we did was last year, we looked at all the pancreatectomies done in the United States. And about 10% of those were for IPMN, and we asked a very simple question. How many of those were low risk and how many of those were high risk? It turns out that even with all this data, 77% of the IPMN we resect in the United States are low risk, meaning lower moderate grade dysplasia on final pathology. And what are these treatment decisions costing us to actually improve patient survival? Well, with the surveillance strategy, it appears you have to spend about $20,000 US per patient to improve a quality-adjusted life year. And with the surgical strategy, it's dramatically higher, over $130,000 to improve a quality-adjusted life year. Now, of course, this strategy will lead to the least number of deaths from cancer, but almost the same number of patients ended up dying from complications of the surgery. So what can we do to improve our surgical selection criteria? Well, I posit we can add molecular pathology, i.e. biomarkers, to potentially improve the accuracy of our guidelines, but also the quality-adjusted life year at a fraction of the cost of surveillance and of the morbidity and mortality of surgery. So what biomarkers have been identified? So in the last year, we re-looked at the literature and saw what is happening around the world to identify different markers in different fluids to help us find out which of these lesions are in fact high risk. And we can divide these molecules into these different rubrics: oncogenes, tumor suppressor genes, glycoproteins, immune modulators, proteomics, and genetic material. And I thought what would be useful this morning would be to go through each of these and see what the best data and the most promising biomarkers are within these sections. And of course, the reason this is possible is the IPMN are shedding their material into the cyst, and you can see a very active picture of that there on the left. So mutations in oncogenes can result in inhibition of apoptosis and unregulated cell growth. The most commonly studied oncogene in multiple malignancies is KRAS, and we know that mutations in KRAS allow uncontrolled signaling through the BRAF-MEK-ERK pathway, which will then increase nuclear transcription. Now, GNAS, when combined with KRAS mutations, increases the sensitivity to diagnose specifically IPMN, and we can see it more often in the low-grade lesions. PI3 kinase mutations trigger AKT signaling. Now, AKT signaling, as you can see in the diagram, works through the mTOR axis and similarly increases cell growth and proliferation. So this is associated in IPMN with high-grade dysplasia and with invasive disease. Now, BRAF mutations are similar to the KRAS pathway and similarly will accelerate neoplasia. Now, hTERT I find incredibly interesting. The job of hTERT is to inhibit telomere shortening. So with every cell division, our telomeres slowly get shorter and shorter and shorter until that cell can no longer divide. That's the normal aging process. But with mutations in hTERT, it inhibits that telomere shortening. So these cells become essentially immortal. And in IPMN, hTERT mutations are associated with increased dysplasia. And then finally, in this category is the sonic hedgehog genes. Now, these are genes involved in apoptosis, and specific mutations in SHH are associated with IPMN dysplasia. Now, as opposed to oncogenes, tumor suppressor genes will protect cells from uncontrolled growth. So aberrant expression will accelerate the adenoma to carcinoma sequence, much like in a colon polyp. Now, worrisome IPMN phenotypes are associated with overexpression of TP53 and loss of heterozygosity mutations or reduced expression of P16, SMAD4, SMARCA4, and RNF43 will all lead to increased cell cycle progression, and with increased cell cycle progression, there's increased levels of dysplasia. Alterations in glycoprotein expression also is related to cellular regulation and dysplasia. So groups have looked at increased serum N-glycans. Those are associated with invasive IPMN. And the question always arises, what about CEA? CEA in the cyst fluid still remains our most accurate glycoprotein to discriminate mucinous versus serous histology. But it's really important to point out, as many in this room are well aware, that it has been shown not to be associated with the level of IPMN dysplasia in multiple studies. Now, MUCs or mucins are very interesting, and these have been studied extensively, particularly in the East, histologically from the tissue to characterize the different subtypes of IPMN. And what we know is that MUC5AC, for example, is more affiliated with the gastric subtype, and et cetera. There are multiple MUCs, 17 MUCs at least, that have been studied associated with different subtypes of IPMN and even different MUC expressions in the different carcinoma, whether tubular or mucinous. When we looked at MUC levels throughout cyst fluid in over 60 patients, we found that increased MUC5AC was indicative specifically of an IPMN pathology, and that increases in MUC2 and MUC4 were associated with high-risk lesions. This is in the cyst fluid. Now, increasing IPMN tumor grade is also associated with an increase in the epithelial to mesenchymal transition, or the EMT. And the classic way to measure this is by ECAD loss, specifically in the cyst. And we find that there is an increase in the EMT as that IPMN converts from a low-grade dysplastic lesion towards invasive cancer. Similarly, markers of a Th1 immune response are associated with IPMN dysplasia. Now, increased tumor-infiltrating lymphocytes as in many malignancies, is associated with increased levels of dysplasia in cancer, and similarly the neutrophil to lymphocyte ratio. Now, when we looked in the cyst fluid of low versus high-risk cysts across a Th1 immune panel, we found that multiple cytokines were actually elevated in the cyst fluid associated with higher levels of dysplasia. But a multivariate analysis, very high sensitivity and specificity, interleukin-1b, perhaps the hallmark of Th1 or pro-inflammatory cytokines, ended up being an exquisitely sensitive marker for discriminating low from high-risk cysts. Other groups, particularly the group in Indiana, has been interested in prostaglandins. And in their experience, cyst fluid prostaglandin increases significantly with increasing levels of dysplasia. So there are multiple cytokines and immune modulators that are being looked at by different groups. Now, cyst fluid proteins can also be analyzed using multi-analyte bead array analyses to determine protein signatures associated with high-risk IPMN. Peter Allen's group has been very interested specifically in this panel of MMP9, CA72.4, Fas ligand, and IL-4. And using permutations and combinations of these 4 proteins, a signature can be created with or without association with clinical features with a concordance index up to 80%. Next generation sequencing has enhanced the use of limited genetic material to detect very low abundance somatic mutations. So a lot of this data has come in the last 5 years or so. Mutational analysis in combination with the clinical features may actually increase the accuracy of not only IPMN diagnosis, but also predicting the level of dysplasia. And perhaps the best study to look at this was a multi-institutional study run through Johns Hopkins, where they looked at many of these tumor suppressors and oncogenes that I've already talked about, but also in combination with loss of heterozygosity and aneuploidy studies that can only be done with high sensitivity using next-generation sequencing. And they used this molecular signature and combined it with the clinical markers, many of which are included in our clinical guidelines, and with up to 89% sensitivity, will predict a cyst that should be surgically removed, i.e. a high-risk cyst of various histologies. Now, what about microRNA? Many groups around the world are interested in microRNA as our technologies to measure these have increased. Now, similar to DNA, they're also shed into the duct lumen. They're highly stable, and we know that microRNAs control RNA transcription, so they're a very nice way to look at not just the genetics, but the epigenetics of what's happening in the cyst. And here's the world's literature on microRNA, and what you can see, mostly through Brian Hobbs' group, is that there are multiple microRNAs. There's over 1,000 that are known, but these signatures vary, whether you're looking at the cyst fluid, the tissue, saliva, blood, etc. So much more work needs to be done in this field, but it's still very exciting to see many signatures starting to arise. So how do we put this all together? I just gave you a whole bunch of science. Many groups are investigating multiple different tissues. The cyst fluid, I think, is representative of the entire cyst. We can obtain it preoperatively and almost routinely preoperatively through EUS in the US, and genetic material is shed into the fluid and it can be analyzed directly without a lot of pre-processing. So Claudio Bassi had the foresight to put a group together about 4 years ago now to try and look specifically in the cyst fluid to see what biomarkers may be the most promising. And we looked at EUS, cytology, tumor markers, MUX, cytokines, and genetic material, and then spent the next few years putting together a cyst fluid bank from multiple centers around Europe and the US, and identified a panel of what we felt were the most promising cyst fluid biomarkers. And what we wanted is to create a single platform. So instead of using proteomics, NGS, PCR, ELISA, we created a PCR backbone-based profile. This can be run for pennies on the dollar. Our goal was to differentiate high from low risk cysts, so a binary classification with a readout of AUC. And what we found was that with the signature of these PCR-based genes, we could come up with an accuracy of 86% to differentiate low from high risk cysts. So this exemplifies a low-cost single platform assay with data-driven targets to create an optimized model that can help predict high-risk IPMN. And maybe some of these patients can avoid surgery if they are low risk, if you believe in a surveillance strategy. The next steps, of course, are to overcome model overfitting and to fine-tune and validate these with additional samples, which throughout the world are quite valuable. One way to approach this is through the Early Detection Research Network, which is a pancreatic cyst biomarker alliance through the NCI. We've recently begun collaborations with them, and I wanted to highlight some of the other panels that different groups are putting together in their own labs. So UPMC is working on something called PancSeq. This is an NGS-based assay. Many of these I talked about today, the different oncogenes and tumor suppressors to create a signature. Telomerase expression and DNA methylation, amongst other panels, are being studied at Hopkins. Different proteases at UCSF. There's an antibody to this protein called DOS1 that has been shown to be associated with high-grade dysplasia. The group at WashU is interested in studying that in additional samples. EGFR ligands are being studied at Stanford, and in Michigan they're interested in glycoprotein signatures. And this is just the tip of the iceberg of what's happening around the world, but these are some of the groups that have come together in the Cyst Biomarker Alliance. So the hope is that as we create these guidelines, we can augment these guidelines with biomarkers and with molecular pathology to improve their accuracy. I thank you for your very kind attention, and I'd like to acknowledge, of course, the IHPBA and the moderators and our sources of funding that help with much of this research. If you find yourself in Chicago, I hope you come by and say hello. Thank you for your kind attention.
Thank you, Dr. Maker. That was a tour de force. I was getting excited that we might, just stay there for a minute, I was getting excited that we might have a panel to institute in the near future, but then, of course, there's so many other panels being looked at. What can you tell us in terms of what we should do within the next 12 months in our practice, based on this proliferation of molecular biology?
So from a molecular pathology perspective, I think the most important thing you can do in your institute, if possible, is to bank your fluid, one. Number two, ask your pathologist to specifically discuss your levels of dysplasia and go down to the pathology, see what those cysts look like, see if the fluid passes the string test, very basic things. And in your own practice, start to incorporate almost an X-ray vision so you can anticipate which of these cysts may be high risk versus low risk. From a molecular pathology perspective, in addition to banking it and participating, hopefully, in some of these larger studies or studies in your own institutions, it would be great to use CEA measured to use for mucinous versus serous and see if in your experience also does not correlate with dysplasia. And if you have the ability to run KRAS and GNAS mutations and you don't know the diagnosis of your cyst, they can be very sensitive and specific to differentiate an IPMN from other cystic histologies.
Thank you very much. Okay.